Welcome back, everyone. For this lecture, we're going to start our journey down the cardiology series for paramedics. This is oftentimes one of the most dreaded and most complex topics when students are looking at going into paramedic school. My goal in teaching you through these next series of lectures is to really help you understand the physiology behind cardiology, ECG interpretation, and understanding how rhythms are generated as opposed to just memorizing individual rhythms. The reality is, if you attempt to be successful in cardiology by just memorizing rhythms, you're not going to be able to fully grasp or understand the nuances that are present in the patients that you treat or the rhythms that you see. And so we're going to start from the ground up and really looking at how a rhythm is produced, what the key components are within the heart, understanding the electrophysiology and how the monitor picks up and traces or displays this information to you, and what the heart is actually transmitting or doing so that the cardiac monitor can pick those up. We'll start off in this series with understanding some basic anatomy and then looking at physiology and electrophysiology of the heart to help us better understand where we go from here and help us develop that toolbox for interpreting those cardiac rhythms. Firstly, let's look at the anatomical blueprint of the heart. So as you learned in anatomy and physiology, and if you've been in paramedic school, you probably learned in patient assessment already, that the heart is located pretty well in the mediastinum, or the middle portion of the chest. It is angled slightly so that the base of the bottom of the heart, or what we would call the apex of the heart, points toward the left side, with the apex being the fifth intercostal space midclavicular line. That's what we would call the point of maximal impulse. And the upper portion, or the top part of the heart, being between the second and third intercostal space of the right sternal border. And so it's rotated just slightly within the chest wall cavity itself. And then it's also rotated along its axis so that the left ventricle is more forward facing or anterior than the right ventricle, which is more posterior in its orientation within the chest wall cavity. As we study ECGs and electrophysiology, there's going to be a lot of reference to what we call the axis of the heart. And this is important to understand early so that when we talk about what a normal axis looks like, or I'm describing that term to you, you understand what we mean. The axis vector line is the mean electrical flow of activity within the heart. So in a normal conduction pathway, the electricity flows from the top of the heart to the bottom of the heart. And it runs along that from the top of the portion, so the second or third intercostal space, right sternal border, down towards the point of maximal impulse, which is the fifth intercostal space, midclavicular of the left side. Okay, looking at conduction pathways of the heart, we're going to start with the primary conduction node, or the foci, which is another term you'll hear a lot of electricity. The primary foci, which is the source of electrical activity, the SA node. The SA node in a normal functioning conduction pathway is what generates the electrical impulse to start the depolarization of the heart. The SA node fires, it travels through internodal pathways along the atria, and it lands its way within the AV node, which is located at the base of the atria. It then proceeds through the bundle of His, diverges to the left and right bundle branch as it travels down toward the apex of the heart, and then back up to the Purkinje fibers where the electrical impulse then terminates. Again, this is the normal pathway. So every time the heart contracts, that depolarization event is triggered by the SA node traveling through the internodal pathways, causing the atria to contract, arriving at the atrioventricular node, or AV node, where it pauses for just a moment, and then transmitted through the bundle of His, the left and right bundle branches, and then through the Purkinje fibers, where it terminates. And this process happens over and over again for every cardiac cycle. You can see that the heart is wired, particularly in the ventricles, asymmetrically. This will become important when we talk a bit about 12 leads, and we talk about cardiac blocks later in this lecture series as well. When we talk about the bundle branches, and so you can see at the middle portion of the heart, right, where the atria and ventricular are joined would be the AV node. It passes down the bundle of His, then it deviates into the left and right bundle branch. We further track the left bundle branch into what we call fascicles. The left bundle branch divides into the left anterior fascicle, which moves around the anterior portion of the heart, and the left posterior fascicle, which is around the posterior side of the left ventricle. We spoke a moment ago about the role of the AV node. The AV node is a delay node. When a normal impulse occurs from the SA node and travels through the internodal pathways, it's paused at the AV node for a brief period of time. This allows for the atria to fully contract and the ventricles to fully fill with blood before the ventricles depolarize and contract muscularly, ejecting the blood into the circulatory system. This AV nodal pause is important to make sure that we get appropriate filling of the left ventricles, and when it does not function, that can create problems for perfusion later. There are extranodal pathways that can exist that bypass this AV node. And we'll talk a few about these later when we talk about things like early depolarization rhythms or conditions like Wolff-Parkinson's-White. These are when there are extranodal pathways so that when the SA node fires, the electrical impulse bypasses that AV node, that AV junction, and causes immediate depolarization of the ventricles or early depolarization of the ventricles. This doesn't allow for appropriate ventricular filling, and it can create states like sicular depolarization, where electricity circularly moves around the heart, causing rapid fire and rapid depolarization of the atria and ventricle. Okay, let's talk about the pacemaker hierarchy a bit. So as I mentioned, the normal pacemaker, the normal foci or concentration or initiation of electrical impulse in a normally functioning heart is the sinoatrial node, the SA node. When the heart is functioning, this node fires at rest at between 60 and 100 beats per minute. That's what we would call its normal firing rate. That 60 to 100 beats a minute from the SA node is our baseline, is our normal. As the heart electrical system deteriorates, or there's a pathology present within the patient, the SA node may fail to function in its entirety. The next point where we call the next pacemaker down, if you will, the secondary power point, is the atrioventricular node, or the AV junction, rather. When the SA node and the atria have failed, the heart will move itself down to the AV junction and will begin to generate electrical impulses from that area. This has an intrinsic firing rate of 40 to 60 beats per minute. So if it was a junctional rhythm, a rhythm that originated from the AV junction and had a rate less than 40, it would be too slow. A rate greater than 60 would be too fast. The last conduction pathway within the cardiac electrical system is the Purkinje network, the ventricles, if you will. When the SA node has failed, the AV junction has failed, the heart will make a last-ditch effort to generate its own electrical impulse from the ventricles. The intrinsic firing rate of the ventricles is 20 to 40 beats per minute. You do need to commit these intrinsic firing rates to memory, as everything that exceeds that intrinsic firing rate we will label as tachycardia or too fast, and things that are slower we will note with Brady-type dysrhythmias. Okay, let's dive into the action potentials and what's actually going on within the heart and what the ECG machine is actually monitoring. As you learned in anatomy and physiology, and as we've discussed previously in pathophysiology and other areas of preparatory sections in preparation for cardiology, nerves and action potentials for muscles are all based in electrical states. This is no different for the cardiac muscle. The contraction that occurs is a depolarization event that is a rapid transition from a negative state of electrical threshold, a negative 90 millivolts is the resting phase, to a positively charged gradient. This causes the cardiac muscle to contract. And this is a chemical process that generates an electrical change, which is what your ECG monitor is actually reading. It's reading those changes in electrical impulses throughout the cardiac muscle. This is why it's also really important to note here that a rhythm on an ECG machine doesn't mean the heart is actually contracting. It means there is electrical transitions in the cell wall, but it doesn't mean that there's actually blood being ejected from the heart and perfusing the patient. An ECG rhythm is not a pulse. It's a graph of electrical activity. We'll go into this a little bit more detail here on the next slide. When we look at the action potential, we talk about the 5 phases that occur. So we've zoomed into the individual cardiac muscle cell when we're looking at this, and we're looking at the cellular wall gradient, or the charge of electrical ions inside or outside the cell based on what's occurring. Phase 4 is the resting phase, and this is where we start. Even though it's not intuitive, this is where we start. The baseline is negative 90 millivolts, and so that's the state of charge in the cardiac muscle cell at rest. When the SA node fires, it has to fire with enough energy to bypass what we call an activation energy threshold. So as you can see on the slide here, it takes a little bit of energy to push past that. And this is to prevent erroneous depolarization or excessive depolarization. There's stimulus coming into the cardiac muscle all the time. This can be from impacts, from vibration, from nutritional states, from stray electrical current. Any number of things can cause a little bit of energy to flow to these cardiac muscle cells. And so the body has evolved and built itself a way to protect against these stray small impulses to not discharge the heart or cause the heart contract every little impulse that comes through. So when the SA node fires, there's a rapid transition that occurs. Sodium enters into the cell and you have a rapid depolarization, and this is phase 0. And we can see that rapid transition from negative 90 millivolts all the way up to 20 millivolts. Phase 1 is when the calcium channels begin to open and allow the flow of calcium ions. Phase 2 is when the calcium channels close. And then phase 3 moves into the potassium channels closing, and you see the rapid depolarization and return to the resting state. There are some important things to note on this graph. Don't expect you to be an electrical engineer or understand exactly how these millivolts relate to various different components. But this graph, this chart, when we talk about the action potential, you should notice some things that are really important here based on your studies of pharmacology. Sodium, calcium, and potassium all impact how quickly or how long the depolarization cycle lasts and how fast we move into repolarization. The vast majority of the cardiac drugs that you're going to administer when you treat patients work on these electrolyte channels. For example, calcium channel blockers slow the flow of calcium. Sodium channel blockers delay the amount of sodium entering in and changing the depolarization rate. Things like potassium excess or potassium depletion can affect the repolarization time of the cardiac muscles. This chart and understanding this chart is how you will decide what medications to give and what not to give when choosing within a specific recommendation or class. Likewise, we can adjust the energy of activation required to make a heart more sensitive or less sensitive to electrical activity. Here's how these phases actually align with the ECG. So phase 0 works during the at-rest state. So that's when on the ECG, everything is along the baseline. There's no electrical activity occurring. As phase 0 moves and you move into phase 1, you can see that we have depolarization events occurring in the ECG. These are the large spikes that you see, and that's the ECG machine measuring the transition of electrical activity moving throughout the heart. And you can see phase 2 as we move into phase 3 in the repolarization phase, and phase 4 back into resting phase. This is how your ECG machine actually measures what's going on within the heart. Okay, couple of things to note as we go through this. During depolarization and during repolarization, there are periods known as refractory periods. When we talk about a refractory period, an absolute refractory period is referring to a state of active depolarization when all of the ions have moved into their respective position and the heart cells, the cardiac cells, no longer have the ability to generate electricity and discharge. You've drained the battery. Essentially, you've had the conduction from the SA node, you've contracted all the muscle cells, and the muscles have not had a chance to recharge yet. And no matter what impulse is delivered to those cardiac muscles, they cannot depolarize. That's the absolute refractory period. There's also a period known as a relative refractory period. And this is the one that I want you to pay close attention to. The relative refractory period occurs during repolarization of the ventricles, during what you will learn later as the T-wave portion of the ECG. The heart at this point has partially reset. Some of the batteries have recharged and some of the batteries have not. And that means if a stimulus enters the heart during that period of time, it can create a state of electrical chaos. If a stimulus large enough hits those cardiac cells, the cells that have charged their batteries will immediately discharge and depolarize, while the cells that haven't had an opportunity to recharge yet can't do anything. They're still in that absolute refractory period instead of that relative refractory period. This can create electrical chaos and really can create some complicating dysrhythmias that present for the patient and don't allow for perfusion. And we'll talk about some of what those can be as we go along. But those are key components that I want you to understand as we discuss the physical and chemical components of that electrical depolarization. Okay, let's talk a little bit about how, or refresh, if you will, some of the things that impact how the heart functions. If you'll remember back from anatomy and physiology, the sympathetic nervous system is the gas, right? It increases heart rate or increases chronotropy. It increases dromotropy, that's conduction velocity, and it increases ionotropy, the force of contractility. These are key words here that I want you to pay attention to, as when we look at medications to impact the cardiac conduction system, we will see things like reduces chronotropy or reduces dromotropy or ionotropy. The parasympathetic nervous system is your brake. Activation of the parasympathetic nervous system will actively decrease the heart rate, actively decrease the conduction velocity. Ionotropy on the parasympathetic side may vary widely depending on the compensatory mechanisms that are in place as the body's measuring its ability to perfuse itself. Okay, key takeaways for this portion, and I know this is a lot of information. Take some time and understand the physiology. This is going to be the key to your success. Don't just try and memorize these things, try and learn the why. And as we look in the next lecture series, we're actually going to look at the cardiac monitor and how it picks up on these electrical changes, and we'll help to apply those into those future rhythm interpretations.